Well, it's great to participate in this symposium, and I thank the organizers for inviting me. Just for purposes of full disclosure, I want to say that I've been a consultant to, have received research funding from, or have an equity interest in these entities. So what I'm going to talk about today is I'll provide a brief overview of Delta, its life cycle and targets of new therapies that are in development, and focus on a review of the new therapies that have actually advanced into combination treatment. So Delta is present everywhere in the world. The only countries that don't report it are those that don't test or their tests don't work. But if you screen properly for it, you can find it. Although the percentage of the HBV infected population that's co-infected with Delta does vary by region. And the molecular basis for why Delta is always found in association with HBV is found here. This molecular view of the virus emphasizing has a single-stranded circular RNA genome, complex with one protein, the delta antigen, which exists in two forms, a small and a large. And these are surrounded by a lipid envelope in which are embedded the viral envelope proteins. These proteins are HBV surface antigen. They're stolen from HBV, and that's why clinically we always find Delta in association with HBV. The net effect is to make the B disease worse. Indeed, Delta is the worst form of human viral hepatitis, with more rapid progression to cirrhosis, liver cancer, and death. About 20 million people are infected worldwide, and there's no FDA-approved therapy. This is a schematic of the life cycle, emphasizing that there's an initial attachment and entry event via the sodium taurocholate cotransporting polypeptide, NTCP, the bile acid receptor. And then after an uncoding event, the genome gains access to the nucleus where replication occurs. This is all RNA-dependent RNA replication, no DNA intermediates, no archiving. Newly replicated genomes then exit the nucleus, associate with the delta antigen, in particular the large delta antigen, which undergoes a specific lipid modification where a prenyl lipid is covalently attached to the delta antigen. Hence, the process is called prenylation. This is essential to mediate assembly with surface antigen envelope proteins and release through the secretory pathway of the cell. So the first class of inhibitors that has been developed based on this knowledge are so-called entry inhibitors, exemplified by Merclid-XB, which block the initial attachment and entry event. And this has advanced into clinical testing. There's the nucleic acid polymers, exemplified by Rep2139, which seek to block surface antigen secretion. Then there are prenylation inhibitors, exemplified by Lunafarnib, which block the critical prenylation-mediated assembly step. And there is interferon lambda signaling. And I will now focus the rest of the talk on the therapies, these new therapies that have advanced into first combination treatment. And that involves Lunafarnib combined with pegylated interferon lambda. So I'll briefly review each of these separately and then focus on the exciting new combination data. So Lunafarnib is a small molecule inhibitor of a host cell farnesyl transferase. That's the enzyme that attaches the prenylipid onto the large delta antigen. And it has been clinically tested in the series of phase 2 studies, starting with the proof of concept study at the NIH and the so-called lower HDV 1, 2, and 3, 4 studies, which sought to identify optimal combinations of Lunafarnib with ritonavir in low dose to maximize the PK and the dosing alone or in combination with interferon alpha. And collectively, these have identified the most promising regimens to take into the phase 3 registration study. And these came out mainly from the lower 2 study, where Lunafarnib 50 milligrams BID with low dose ritonavir 100 milligrams boosting achieves around a 2-log drop at the end of 24 weeks as an oral monotherapy. And when combined with interferon alpha, there's synergistic activity to approximately 4-log drop at 24 weeks. And that can be compared to where standard pegylated interferon alpha alone achieves. And so these regimens now have been taken into longer dosing for a total of 48 weeks, duration in the liver study, which is the phase 3 registration study, looking at Lunafarnib all oral, alone, or in combination with pegylated interferon alpha, and comparator arms of pegylated interferon alpha or placebo. Over 400 patients now fully enrolled, with a primary endpoint being greater than 2 log drop in HDV RNA and ALT normalization at 48 weeks, end of treatment. So that's Lunafarnib. Now, pegylated interferon lambda is a type 3 interferon, different, importantly, from type 1 interferons like interferon alpha. They both have pretty much the same post-receptor antiviral signaling. However, interferon lambda is much better tolerated because, as we'll see in a moment, its receptors are much less widely distributed in the body. Interferon lambda has been evaluated in over 3,000 patients in the context of over 20 clinical trials, mainly in the context of hepatitis C, hepatitis B, where the drug was been given once a week for 48 weeks. And the net effect, again, is that comparable activity has been demonstrated, but interferon lambda is much better tolerated. And this is the basis for that the receptors, again, for lambda are much less widely distributed in the body. And that's why there's much less of the typical interferon type 1 symptoms when you use the type 3 interferon lambda. And so in Delta, this is the first study looking at interferon lambda in Delta, the so-called LIMIT study, which looked at a standard dose of 180 micrograms given once a week subcutaneously versus a low dose of 120 micrograms for 48 weeks treatment duration, and then 24 weeks post-treatment follow-up, with the goals were to demonstrate comparable activity to historical pegylated interferon alpha when much better tolerability. And indeed, here's the top-line data. Importantly, the standard 180 microgram dose did indeed give comparable activity compared to historical pegylated interferon alpha and was much better tolerated. Many of these patients had been on interferon alpha before and saw a dramatic difference in the improved tolerability with interferon lambda. And again, this just to put that in perspective and highlighting that indeed the 2.5 log drop seen with interferon lambda is right in line with what has been shown in interferon alpha. Here's just one example from one of the largest studies. They hit a 2 study looking at pegylated interferon alpha, same 180 microgram dose at 48 weeks, comparable efficacy to what we saw with lambda. Now, this is the important post-treatment follow-up from the LIMIT study, looking at demonstrating that 36% of patients had a so-called durable virologic response. So 24 weeks after stopping treatment, they were below the limit of quantitation in terms of HDV RNA levels. And interestingly, this is some data from the group out of Israel, which participated in this study. Some of the patients had received a liver biopsy before receiving interferon lambda. And here's 2 patients who had a repeat liver biopsy 18 months after lambda therapy, demonstrating pretty dramatic reductions in fibrosis as a result of the lambda therapy. And this has now set up the phase 3 registration study of interferon lambda, which is starting this year, where a relatively small study of 150 patients in 2 arms will look at, again, the same exact dosing regimen that was in the LIMIT 1, 48 weeks of interferon lambda. 1/3 of the patients will have a delayed onset of treatment, providing a control arm, which will then be used as the primary endpoint comparison with the 24-week follow-up HDV RNA levels from the larger arm. And just because, of course, the organizers of this conference have demonstrated some dramatic other benefit of lambda, I do want to give a little plug to them. And they investigated right here or there in Toronto, interferon lambda for COVID-19, and demonstrated dramatic efficacy in a placebo-controlled study with a p-value less than 0.01 in terms of viral load reduction, and the higher baseline viral load, the greater the odds ratio in favor of interferon lambda. And that phase 2 study helped set up the phase 3 study, which is ongoing right now in the so-called Together trial, which is an adaptive trial design, randomized placebo-controlled, looking at different agents, all of which pretty much have fallen out, and the only one remaining is interferon lambda. And we expect the results from this study to come out by year's end. So now we finally can come to the first combination of two therapies, of these new therapies together for Delta. And this is the so-called LIFT study, which looked at the Lunafarnib ritonavir dose given in the phase 3 registration study, combined now, however, with interferon lambda instead of interferon alpha for 24 weeks duration with a 24-week follow-up. Primary endpoint being greater than 2 log reduction in HDV RNA at the end of treatment, and then histologic improvement at the end of follow-up. And so the top line data is 77% of patients achieved the primary endpoint. 50% had undetectable HDV RNA, and this is just after 24 weeks of treatment. So very dramatic data. Overall mean log decline of over 3 logs at 24 weeks. And importantly, in the follow-up, 24 weeks after stopping treatment, 23% durable virologic response. And over half the patients had improvement in the histology activity index, with 30% having over 2-point improvement in HAI. So the take-home message is that Delta is found everywhere. The percent of HBV patients co-infected with Delta varies by country. It's the most severe form of human viral hepatitis. Fortunately, studying the HDV life cycle has identified many potential host targets for antiviral intervention. Several form the basis of drugs that are in clinical development that target entry, prenylation, surface antigen secretion, and interferon lambda signaling. These are all complementary mechanisms of action, so they offer the potential for combination therapy among these different new therapies. And indeed, the first example of a combination of new therapies has now been conducted, and consisting of oral Lunafarnib with once weekly interferon lambda, a subcutaneous injection. And this is really the beginning of an exciting new era that I think offers some great promise for our Delta patients. Thank you.